These are the standard instruments that will be used in the delivery of a splint. My favorite slow-speed acrylic burr is this burr right here. It has a nice rounded tip on it, which mimics the lingual surface of a maxillary incisor and gives a nice contour to the incisal guidance of the splint. So that's the burr that I prefer to use in the slow-speed handpiece. I also will hold the handpiece in this manner so that I've got better control and better power. So I use the palm thumb grasp on the slow-speed handpiece because it gives me better power and control. I'll also create a pivot point on an opposing hand finger, and that way I can use the handpiece in this manner to do adjustments. I also support the splint with my fingers, so in whatever position I'm in, I'm able to put support on that while I'm making adjustments as needed. The favorite articulating paper that I like to use is the Accufilm 2 paper. This is the standard occlusion paper. Accufilm 2 is not as affected by saliva, and so you can use it throughout the procedure without losing any of its accuracy. I always use 2 of the Miller forceps to hold the articulating paper both in the mouth at the same time, so that bilaterally the attention of the patient is centered and the patient is not trying to reach to one side or the other to contact the paper and make an imprint of their bite relationship. Of course, I use the double-sided mouth mirror, and I also use the cleoid discoid primarily if I were trying to remove a splint that I had done an internal reline with. I can use the cleoid to engage underneath the lip of the splint to remove it without creating a smudge on the fresh acrylic that I've put into the splint. Basically, those are the main instruments I use. At the end of adjustments, I will usually polish with the gray rubber tip and the light green rubber tip. A word of caution, the light green rubber tip is prone to disintegrate or come apart from the shank, and if you're going to use it, it's best to have the surface of the rubber tip touching the surface of the splint when you start the rotation of the handpiece, and that helps to control the wobbling of that material so that it doesn't disintegrate as easily. We're going to start out by refitting an existing splint that the patient has worn before and has fractured. You can see here where the canine guidance area is, and also some fracturing here in the distal on the left side. That usually indicates some heavy grinding or clenching. However, the splint is quite thin. Ideally, we want the splints to be thin enough so that ultimately when we transition off the splint and onto the natural teeth, it's not that much of a vertical dimension change for the jaw to deal with. So we're going to change now to intraoral. We will demonstrate these procedures using her splint and adjusting and correcting as needed. So as you enter the mouth to position the splint, it's a good idea to bring a finger in and just retract the cheek so that you can slide in without catching the cheek. Also, before you seat the splint, it's a good idea to bring an index finger up into the vestibule so that the splint doesn't catch the cheek and pinch. Now that it's in place, we can see that it is stable. Emma has indicated that this has been very helpful for controlling symptoms for her jaw. And so we're just going to get some marks here now. Tap together, please. Open. Tap again. And open. So I like to get both anterior and posterior contacts. If you look closely now, you can see that there are contacts occurring on the incisors, and you can see those marks that will correspond to contacts on the splint itself. and I'm seeing a good distribution as we go posteriorly onto bicuspids. All of the functioning cusps of the lower teeth are making good contact on the splint material. I'm going to slip it out now. In doing that, I also was testing the retention of the appliance to make sure that it's retentive enough that it's not falling out and she's constantly clenching to try and keep it in place. As I look at the marks that I see that have developed from the tapping, we're a little bit heavy here in the right first molar area and perhaps in the left first molar area as well. Did you feel any discrepancy, or was it even on both sides?
It's pretty even.
Okay, so that's a pretty good indication of stability in terms of centric relation. I am going to lighten the contacts on the left because they are so much darker. It doesn't take a lot of change, and you'll see that because I have contacts on both sides, I've retained a small part of the right side contact to match with what's on the left side. I'm also noticing a wear facet here in the plastic that corresponds to an opposing lingual cusp of a mandibular first molar. And there's a mark corresponding to that. So technically that is a non-working interference on the splint that I'm going to remove fairly aggressively so that we don't have to worry about that creating any kind of muscle reaction. As I do this, I also smooth the area to try and keep it from becoming rough or sharp. Also, during these adjustments, it's nice if you have an assistant who can blow air across from this direction so that all of the shavings are blown away from the patient. So we'll try this back in now, and we'll look at, go ahead and blow the air on my gloves and the appliance. So again, we're trying not to carry any of the acrylic back into the patient's mouth. Thank you. We'll slip it back in place. Protect the cheek. And then we'll get some new marks. Just tap straight up and down. And open. I'm also going to have you now bite together and grind side to side and forward and back and open. Again, bite together, go side to side and forward and back and open. In doing that, I'm also testing the eccentric movements and the potential for interfering contacts on the appliance. Bite together, please. I'm going to have you now slowly slide your lower jaw to your right, keeping contact on the splint. Hold it. As we do that, I'm looking to see if we have posterior lateral contacts. And in this case we do, primarily because there's a groove now carved through where the canine guidance was. As I look on the non-working or balancing medial-obtrusive side, I see a slight separation, but still fairly close. Now back to normal bite and slide to the left and hold it there. On the left side, I get a better separation. Can you see in the mirror where that is separated from the acrylic from the teeth? And also on this side, we get a better separation. So we have canine guidance in this respect. Back to normal. And come straight forward, please. Hold it. In protrusive now, we're actually getting our protrusive off of the first bicuspids. And that represents more of a protrusive interference, which may actually contribute to some of the grinding and clenching that we're seeing. So open. So I'm going to true things up here a bit to try and make it less of a tendency for it to cause that grinding. So now I've cleared that out, hopefully enough to give us better function. I don't see any other interferences in the lateral and protrusive movements. So we're going to call that good for now. For this older appliance, it's still serviceable. It still has bilateral, simultaneous, stable occlusal contacts. And that's what we're looking for, and you can see those quite well now on the surface of the splint. Often and usually, I want the patient to verify the contact freedom and stability. So Emma, I'm going to have you put that back in and tell me if there's any tooth that calls your attention to it, as it might be hitting sooner or harder than the rest.
Feels pretty good.
Feels good? Okay, and that's about all we're going to do with that. To rebuild the canine guidance on this would probably not be effective because it's so thin and there's so much missing that we can't bond to it properly to rebuild it. But it's still a good backup appliance. So let's slip that out. Oh, do you feel any roughness or sharpness with your tongue?
Right there.
Okay.
But that might be where I broke it.
Well, partly, but I can smooth that.
Other than that, no.
Okay, open. So I think where the patient feels that sharpness, it's important to take a moment and try and soften that to make it more acceptable so that there is not a tendency to play with it, even subconsciously. So I'm just going to lightly shave that and round it a bit, and then also these areas where the actual fracture occurred. Because we still have centric contact. Well, Emma actually did when that fractured was she probably eliminated a lateral trusive interference. So go ahead and put that back in and feel that with your tongue.
That's much better.
Is that better?
Much
okay.
better.
Slip that out. We're now going to go to the new splint. It's never been tried in before, but we've all examined it and it looks really nice. It is a little bit thicker, which we want. The lab that we use has done an excellent job of making these conform to the criteria that I want for our splints here at the dental school. Here is the pre-existing splint. You can see that it's had some fracturing and some wear. It's quite thin. It's still serviceable and helping. Here's the new splint. It's a little bit thicker. It gives us a little more working room, and it should actually solve the problems that we were seeing with lack of disocclusion in the posterior in lateral movements. So I'll set this down now and we'll try in the new splint. The first thing that we've done is we've shown it to the patient. Of course, Emma is familiar with what splints are and what they do. And then I will try it into the mouth and first check for stability. So let's check that now. Did you do the scan, Jared?
I did do that, yes.
Okay.
Yeah.
And Jared did the scan. It feels quite stable. I'm not getting any significant rocking. There's a little bit of a shift right here, but not enough to be concerned with at this point. Now, how does that feel? Is it too tight anywhere?
Right there.
Tight on that tooth?
Oh, tight? No. It kind of feels different right there.
Well, it will.
But tight, not really.
Okay. Let's try some marks now then. Let's have you just tap your teeth several times. Open. Tap again. And open. So one thing that I want to do with a new splint on a first try in is take a look at how much space is there between the splint and the lower incisors. That will give me some idea of how much I have to reduce the posterior portion of the splint to get contact on those front teeth. So bite together and hold your teeth together on the splint. And I'm seeing about 1 millimeter of gap, which is really nice. That's not a lot of grinding to have to do. But as Emma's already indicated, she's getting a heavy contact right here. So that's where we're going to focus as we adjust. Open. We've got good retention. It is bound to feel different because it is. So now, if you look closely, you can see the mark that Emma was sensing in that first try-in. We're also getting another lighter mark over here in the bicuspid area, which we'll adjust as well, but our main adjustment will be on the incisal guided area here where it's a little bit premature. I'm also seeing one in the posterior in the second molar area. So we're going to lightly adjust those, but enough to give us the amount of anterior contact that we desire. You can see I'm being very judicious about that reduction, but I'm not wasting any time. I see a lot of students using this technique, and if you're going to paint the splint or draw on it, that's fine. But if you're trying to reduce acrylic, you really need to grab the burr in a palm-thumb grasp and go to work. So I'm going to do a little of that on this right-hand side as well, or left-hand side, and in this area where the bicuspid is making a contact. That's enough for us to see now a new pattern of contacts on the teeth. So we'll slip that back in. And tap together. Open. Tap again. And open. I'm starting to see some contact now with incisors over here. We see the canine again here. Well, let's slip it out and see how we're doing with other areas of contact. You can see now that on the left we have a good distribution. Molars, bicuspids, not quite what we want in the canine. Still contacting in the right side canine, left side posterior teeth. This might be a lower lingual cusp here, so we'll adjust for that. So I'm going to do one more adjustment to try and get us closer to the anterior contact that we desire in a splint. We want to, as much as possible, mimic the ideal anterior guidance on the teeth in the splint. So technically, the splint becomes an artificial, ideal bite relationship. And that's where we get a restoration of orthopedic stability to the joints and muscles. You can see that I'm just being fairly aggressive here on these marks because we've got areas that aren't marking that we need to mark. So we have to take down acrylic where the existing marks are until we see all of the marks that we want. We'll try this back in now. And that's the kind of sound you'd like to hear with regard to retention. Tap together again, open, tap again, and open.
This feels good.
It's starting to get much closer to where we want to be. And I think if we look, we can see marks here now. On the left side, there is a lingual cusp making contact, so we would want to reduce that because that's a potential interference in medial obtrusive and or lateral obtrusive. But we've got a nice distribution again of marks through here. We're still not quite touching in the anterior. So all of these existing marks have to be removed until we start getting marks in the anterior along with the re-established posterior marks. So at this point, I'm going to turn the appliance over to Jared and let him take my role as he finishes adjusting this appliance. It's good for the students first to see me work with it and then actually get the eye-hand experience of adjusting it and also fitting it in the patient's mouth. But it's a really nice appliance. It has come out just really quite nice. If there were rocking in the fit, we would need to assess where the rock is generated from and determine is it more stable in the anterior or in the posterior. Depending on which of those we choose, then we can dry the intaglio surface of the splint, then coat it with monomer liquid, and then mix some snap clear acrylic, and you would place it in here. You do not have to put a lot in here because the fit is quite good. So we're just relining to eliminate the rocking. The rocking that you will be eliminating is where you see the gap in the splint from the teeth when you're in the most stable splint fit. So if I were to press in front and there's a gap back here, and it's rocking this way, I know that I can press in the front. There will be a gap here, but that will fill in with the fresh acrylic and give us a relined fit. You do not ever walk away from a patient when fresh acrylic is setting in the mouth. The risk is, if it hardens, it may lock into undercuts in the teeth that will make it very difficult to remove. And you don't want to go through that experience because sometimes you end up having to cut it off. So you always stay with the patient and with the splint. I like to put a little bit of the material on my glove, watch it, test it while I'm holding the appliance in place. And when it becomes firm but not sticky, and it's firm enough like you might feel the surface of a ball, a basketball or a football, then I'll remove it, check it to make sure that all of the intaglio has bonded well. Then I may set it back in one more time and then remove it and let it finish setting. If I see that it has disengaged anywhere in the intaglio, I can put a drop of monomer right at that point, and we will put it back in the mouth, and we'll see that area heal by letting it stay in long enough for it to recover from that separation.
We're just continuing on adjusting this guard splint for Emma. Go ahead and bite down. All the way back, and then side to side. Okay. And
And forward and back,
forward and back.
and then across the anterior.
And across. Okay. Actually,
You
try
can
that.
do that.
Okay, now forward and back.
And side to side.
Side to
Good.
side. Okay.
Now cross
Open.
these over each other, just in, for me.
Uh-huh.
There you go, like that. So now I'm bringing it back in this fashion. I have it ready for the next pass.
Okay.
Now hold it up so that we can look at the pattern of markings. Do you see any anterior contacts?
I do. So we have a little bit of a start of anterior contacts. We are heavier on one side like we talked about earlier and
Okay.
lighter on the other.
And that's in protrusive also, or just incentric?
Looks like in protrusive as well.
Also in protrusive, look at the distal of the canine rise portion of the acrylic. That would be right over here
Yes.
and back here. If you see any blue marks coming forward on that from the bicuspid, you'll want to relieve that as well.
I do on her right here.
Okay, so you'll want to
Okay.
adjust that so that the incisal guidance is on incisors and not on the bicuspid.
Okay.
Okay? So you hold that, and I like to hold it a little bit away from the patient, and I'll blow the air to keep it go up higher. After you've adjusted several of these, you'll get a feel for how much to take off when you're making these fine-tuning adjustments.
way down, side to side.
Also, just for clarification, I always hold the papers up to the maxillary teeth because they're not moving. The mandibular teeth do, but the maxillary don't, so you're just there for the teeth to come to meet them.
Okay.
Got it.
Okay, so we have.
Okay, you've got some good contact. These are protrusive,
Yeah.
but they are balanced. So both centrals are riding up. You might be a little heavier here, but you've got a nice centric contact here, 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 and I'm not seeing one quite yet over here. These are all looking nice. That's a lingual cusp. So get aggressive on that one.
Okay, get aggressive.
Save
here,
this buccal
here, here.
cusp, but get that lingual. And there's your canine guidance. That's just beautiful. That's perfect. But this is the ridge that she's feeling. You feel that with your finger. There's a catch there.
There it is.
So you're going to just very carefully shave down the catch, but not lose your angle.
Okay.
Okay? If you look at this side, there is no catch. It's just a nice smooth ride up the canine surface. So those are really nice marks. It looks a little heavy here. Can you see how much heavier that tooth is? So look for heavy marks. Look for, you've got the bicuspids cleared all right. Might be a little heavy there, but I think
So.
you could smooth this, lightly this, lightly this,
Okay.
and let's just see what happens over there.
Okay. And I'll show that closer to the camera too. So at this point, we're ready to just go ahead and start taking down some of my heaviest points. So here, here, anterior, and then a couple on the buccal. This ridge right here, we're going to try to smooth out. She's catching right here on this lip. So we're going to lower this contact and then smooth that angle.
Kind of holding this up and adjusting toward the patient. When you're not filming, it's a good idea to turn it away from or to the side so that the acrylic isn't flying onto the patient. But right, we're keeping the acrylic under control with this airflow. So just adjust that one heavy one.
Spray that. Blade together, forward and back, side to side. Okay, open. Together, side to side, front to back. Open.
Now, do you still feel that catch on the left?
Not as much.
Okay. Is it occurring more up front here now?
A little bit right there.
On the canine
Or it feels like the
or
central.
on the central?
Mhm.
Okay. We'll look for
Right,
that.
together. Front to back. Okay.
So I'm seeing a really nice distribution here. This is a bicuspid here. So you are getting more function right through here.
Okay.
You're getting bicuspid rise. You really want canine guidance. So I think as I look at this now, is that a mark right there? Okay, you want to remove that, but don't take any of these.
Okay.
I think if
This
you
is-
take care of this right here
Okay.
and lightly on this, you're not going to lower it vertically, you're going to open it up horizontally toward the labial. That makes sense?
Yep.
So open that up. That's the lip I think was catching in lateral. Clear this, clear that, remove that, and I think you're there.
It's feeling really good.
It feels good? Good. Yeah, this will be a real treat. Often after the delivery, the muscles will adapt, move toward you. Here, and pull it in towards your chest. There you go. The muscles will adapt and the bite will change. And so after 2 weeks, Emma needs to bring this back in and have it fine-tuned to her bite at that time. Usually, there's a little bit of adjusting that's needed to fine-tune it and make it even more serviceable. On that lingual cusp over here, I want to see acrylic fly. So really be aggressive. There you go. Yeah. Really be aggressive getting rid of that. Because the mandible will flex and pick that up. There you go. That looks good. Okay.
How's it feel?
Really nice.
So at this point, that is a key question to ask. Go ahead with remarks. The patient is the ultimate judge on how it should feel.
Front to
If
back.
there's anything that calls their attention to it, subconsciously they may start playing with it during their sleep.
Side to side. Front to back. Open.
Now, one thing I like to do also at this point is have the patient bite together and then watch the incisors as they come forward. Slide forward, right there. See if they're evenly distributed across that
Okay.
protrusive, and to me it looks really great.
Okay.
That's what we want. Also, check in the posterior, you should see that all the posterior teeth are out of contact with the splint. Slide forward. So you see that they're disoccluding.
Yes.
Okay. Forward again. How much space is there between this bicuspid and the splint? Does it look like there's a space there?
Turn towards me. No, it looks like she's contacting.
Okay, so we'll need to look for a mark there. Now back together and slide to the right. See how nicely that separates?
Yeah.
Back together, go left, and that separates, back together. So let's see if there is a mark on the bicuspid area in protrusive. It'll show up on the distal of the canine area. It's possible that it didn't make contact, but it just looked close. I'm still seeing this right here.
Okay.
So that's bicuspid. Here's what you want is the canine.
Okay.
So, and I'm still
one,
seeing
check
that
this
dot
one.
there, so
Okay.
get more aggressive there and remove this rise right here.
So remove this.
Yeah.
Remove that. The interiors look pretty good there.
Interiors look really good,
Okay.
yeah, and Emma likes the way it feels
So
too.
we want to adjust that.
I think we've got it. Just
Okay. Those
this
two.
part here and this
Okay.
lingual cusp over there. So get pretty aggressive with that lingual cusp. You don't want it making contact in a clench.
Okay. How's that feel?
Very nice.
Side to side. Front to back. Open. The interiors, let me this one. Side to side. And front to back. Open.
Thank you. Let her feel that with her tongue. Make sure there are no rough or sharp areas that bother the tongue.
It feels nice.
Good. So let's leave it in for a few minutes. Let's just talk. At this point, we're basically done, and I think the main thing we want to assure ourselves of is the comfort that the patient has in functioning on this appliance. She's indicated it feels good, it feels smooth. Sometimes you have to take more acrylic away, even on the palatal surface, on the cameo portion of the palatal surface. So at this point, we have the splint adjusted to the patient's comfort and stability. The marks look ideal, and the patient's indicated that it feels good. So we can basically go over instructions now on the care of the appliance and when to wear it. If it were to need any smoothing, you would use the gray rubber point followed by the light green one. And it's just a light buffing action that you do to smooth that. If you have your own practice and you have a pumice lathe, it'll be even nicer because it gives a much smoother finish. And so when you can, that's a good alternative. In our clinic, you have to degown, you have to change gloves. If you can get it comfortable without that, it's best just to make it comfortable for the patient. But the key now is patient's comfortable, they're able to take it out, put it in, go ahead and try that. You do some training with the patient. One of the instructions that I will give is I'll show it to the patient. I'll say, when you clean it, hold it like this, not like this. It reduces the risk of distorting it or breaking it. I recommend cleaning it with a soft bristle brush, cold water, and just a little bit of toothpaste. If it starts to develop an odor, you can set it in a mixture of 50-50 water and mouthwash, whatever your favorite mouthwash is. But only 20 minutes, and then take it out, rinse it with cold water, and store it. If there's a dog in the house, they will eat this. It's a very expensive treat. And so always when it's not in your mouth, it needs to be in its case. And we have a case here for you that won't be hard to find when you're looking for it. But even then, it should be up and away from any animals. If you're wearing your appliance in the daytime and you go out to eat, make sure it goes in the case, not on your napkin or on the table by your plate. Invariably, it ends up in the trash. So those are some things that you just need to be aware of. Dogs are your biggest issue, even a friend's dog that comes to visit. Make sure that it's in its case and up and out of the way. For right now, we're just going to have you wear this at night. There's no reason that you can't wear it during the day. If you do, you'll notice a slight lisp, and you can improve that by reading out loud with it in.
Okay.
Your tongue just needs to get accustomed to it being there. And so that's another way that you can deal with that.
Sounds good.
So I think everything is good, looks good, it must be good. Jared, you did a great job.
Thank you.
Emma, you're a great patient as always. So we'll rinse this and give it to you, and let's try it out.
Sounds good. Thank you.
Okay.